Let's move now to the description or discussion about the approved indication for medical cannabis. So here in Europe, again, even if we don't have a generalized regulation on the European level how to use medical cannabis, it's more on national level. Some of the countries have approved medical cannabis use, like Poland, Germany. And in both countries we have this, I was mentioning, approach through the magister formulation. So the doctors are prescribing the medical cannabis, general doctor, not only specialist. And we know that the indication for medical cannabis in Europe while use include chronic pain, especially neuropathic pain, spasticity in multiple sclerosis, certain form of epilepsy like Dravet or Lennox-Gastaut syndrome in pediatric patients, and in oncology and palliative care. So those are areas where clinical evidence is solid. But there is a lot of new emerging therapy indications which have a potential to be solved by the medical cannabis. Could you discuss some of these the indication in details? For example, what does the evidence tell us about cannabis for chronic pain? And also from your own experience, you are medical doctors, what are the key studies or clinical trials which can back up this data? And what are the promising indications in this area for the use of medical cannabis?
Sure. So chronic pain is a big indication, as we talked about, especially neuropathic pain, and that's one of the major reasons that people use cannabis, not only for the pain but also for softer effects related to pain, like sleep. A lot of people that have kind of this vicious circle where they don't sleep, and because of that they kind of think the pain is exasperated. So having something that helps them not only with the pain but also with reducing their anxiety and improving their sleep is important. So pain is a big indication. There was a study done in 2017 by the U.S. National Academy showing that it is effective and there is evidence for use of for cannabis in chronic pain, and that's definitely a indication. As I said, it reduces addiction to opiates, so there's a benefit from our perspective of having the patients less on opiates, because opiates should only be used for acute pain, not for chronic pain, as much as possible. And if the patient has chronic pain, we have to look for other solutions besides opiates, if possible, because the risks related to opiates. So cannabis could be a good alternative or complement and reduce the dosage of the opiates. So that's really related to pain. When you talk about other areas like multiple sclerosis, as we said, Sativex was approved for spasticity related to multiple sclerosis. It is there is a drug on the market for multiple sclerosis. The real problem with that drug is the formulation that causes side effects related not to the cannabis but to the alcohol in the or the ethanol in the spray that causes very severe dry mouth and unpleasant effect to the patient. So a lot of the patients want a 1-to-1 ratio of CBD and THC, but they would prefer getting a formulation from the magistral formulation as opposed to the Sativex.
This is, I have like a question and suggestion, because obviously Sativex is approved drugs. Here in Poland, it's a case where pharmacist is composing this same solution. So here we know that the Sativex is approved for this multiple sclerosis related spasticity. So if the doctor in Poland is prescribing this 1-to-1 ratio THC CBD extracts, the pharmacist can formulate something more patient-friendly. So instead of having ethanolic-based sublingual spray, he can formulate, for example, oily solution, and also use it as a sublingual oil. What do you think about the role of the pharmacy and the compounding here?
I think the pharmacist is very important, actually, frankly, more important than the doctor when it comes to cannabis, because of the titration need and the fact that the patient has to have someone to talk to when they get the prescription, how to use it. So the pharmacist is important. The nurse is also very important. We'll talk about that. The nurse having training, education is very important. The doctor's real role is to really make sure that the drug that's being prescribed doesn't have any the reason not to use it, because sometimes there is drug-drug interaction. We could talk about that. Maybe I should talk about that for a second. As I said, the endocannabinoid system receptors are in the body, in every part of the body. So, for example, during ovulation, there's a dramatic increase in the endocannabinoid receptors in the ovaries. So there's a difference between men and women, and there's also a difference in different times of the year and different parts of life. The same is true for the thyroid system. The cannabis can have an effect on the release of thyroid stimulation, the stimulation hormone, the TSH, and so there's an effect on the different organs in the body, and the doctor's job is to look at the patient and really see what they need, and if they should what they should use. But because everyone is different, I'm going back to what I said, I think we should start low and go slow and really measure after some time and have feedback from the patient.
So close interaction with between doctor and the patients. But let's back to the indication you were starting to describe in details very well. So the epilepsy, because this is very controversial, and especially here in Poland, because even if I'm sorry to be back again to the magister formulation, in the pharmacy we don't have access to the approved by Polish authority extracts, pure extract, broad extract without THC, high in CBD. So we have or high THC full spectrum, or eventually balanced extracts THC CBD, but we don't have in the pharmaceutical grade CBD extract. So we have this high quality food supplement based CBD. Market is flooded by this product, but here we have epilepsy. So first of all, maybe if you can explain us how medical cannabis can help in epilepsy, and also how the doctor in Poland can eventually help for the patient with epilepsy.
So we actually saw this in Israel as well. Having a little bit of THC is okay. I mean, it's all about quantities. So full spectrum is not an issue with use of CBD, even in children. The reason an isolate was the way GW went and got approved was because of the U.S. market. But I think if you look at the science, the full spectrum is actually better. You can get you get the effect with lower doses of CBD. Actually, when you go to very high doses of CBD, you could get liver toxicity even with an isolate. So the full spectrum has advantages of as opposed to even the isolate, and you can use a full spectrum CBD with low THC as much as possible for epilepsy. Mishulam and some researchers in Brazil actually showed this is really interesting, in the early 80s, that they did a study sponsored by the researchers on epilepsy in the early 80s and showed dramatic effect on epilepsy in Brazil, and it took over 30 years to get the drug approved. So there's no reason to wait till the drug approved, and the drug that's approved is very expensive and not necessarily better. So I think magistral formulations are fine, but you want to go with the lowest possible THC as possible.
And let's talk now about oncology and palliative care, because here approach is quite different. I think even the palliative care, you have so many symptoms, indications, you can use medical cannabis, the same for oncology, because the side effects on the oncology treatments also can be counterbalanced by medical cannabis therapies. Can you elaborate maybe also these two groups of use for oncology patients and palliative care, how to approach it from medical perspective?
Sure. So first of all, it's supportive care. It's not to really treat the cancer. Although people talk about cannabis treating cancer, I doubt that we have enough data to support that. Really, it's supportive care to improve the patient's quality of life, both reducing their anxiety, improving their sleep, improving their appetite, so they could combat the muscle wasting and cachexia that we see in cancer. So I think that's definitely an area that we should be prescribing. I think every patient that has a cancer should get cannabis. Maybe everyone should get cannabis, but definitely every cancer patient should get cannabis, because it reduces their anxiety, and it's a very stressful period to go through the therapy for cancer. So it helps them, and there's a lot of data showing that improving the kind of quality of life in oncology patients improves the outcomes. So I really believe that it should be given to all oncology patients. Not to treat the cancer again, but to really improve their quality of life. When it comes to palliative care, for example, agitation and Alzheimer's, that's a big area of research now. It's a big problem in nursing homes where there's agitation of Alzheimer patients, and what doctors are prescribing are very potent drugs that actually kill the patients, like the antipsychotics and so forth. And so giving cannabis to these patients not only will reduce the anxiety in the patients, but also improve the quality of life of the nurses that are treating these patients. And so I think it should be used in palliative care much more frequently.
I will back to oncology patients, because we have also the group of the patients with HIV/AIDS. So they have a severe weight loss or appetite loss, and here there is the side of medical cannabis calling often munchies, which can be used here as a therapeutic use. So can you elaborate maybe here slightly about this?
Sure. So as you said, cannabis, one of the effects of cannabis is, THC in cannabis is the munchies, increased appetite, and that's something that could be used as a benefit in cancer and HIV patients. That's what dronabinol was approved for. When it was approved, it was really for muscle wasting and nausea in cancer patients. So there's no reason not to use cannabis-related products in oncology and HIV patients.